Good afternoon. We will be starting our special Glaucoma Society of India symposium. We are really honored to have our President Dr. Barun Nayak sir and Dr. Pandav sir, immediate past President GSI, to chair the session. We have esteemed panel, Dr. Maitri Das, Senior Glaucoma Consultant from Calcutta. Dr. Vibhuti Sinha sir, I think will be joining us soon. Dr. Sumita Mahapatra madam and Dr. Ajit Dwivedi. Our co-chairperson will be Dr. Pranav Ranjan, who is the President Bihar Ophthalmic Society. I'll request our first speaker, Dr. Sweta Tripathi, to present on assessing glaucoma progression on OCT. Dr. Sweta is a senior glaucoma consultant at Indira Gandhi Eye Hospital, Lucknow, and also the Central Zone representative of Glaucoma Society of India. We request the panelists to come to the front. The hands to make. Nice. Please, sir.
A very good morning. I can say a very good afternoon to all. And at the outset, I would like to thank AIOS and especially my seniors of GSI for giving me this opportunity. So straight away coming to my topic about talking about the assessing glaucoma progression on OCT. So before that, let's see that why this is so important that we need to see the disease progression in time. That's because when we look at the glaucoma burden projected through this systemic review and meta-analysis, as projected by Them et al., it is estimated that by 2040, 66.83 million people worldwide are going to get affected by glaucoma, currently jumping from 46.24 in 2020. That's a huge burden on the society because that's a permanent blinding condition. So, as we know that the goal of glaucoma therapy is control of IOP, alongside we have to keep a good quality of life, keeping in mind the progressive nature of the disease, and that is how the importance of identifying the disease progression comes in time. So the need of the hour is to identify the progression or the disease as early as possible and as accurate as possible, with the help of the quantitative and objective imaging devices, which are more sensitive to detect the supple changes when we call it as progression. So if we are so clear in our mind, then what is the challenge? The challenge comes when we have to race against the time. That is the ongoing age-related ganglion cell losses already there, and the adequate number of objective and sensitive tests for diagnosis is not there. And last but not the least would be the variable rate and pattern of progression needs to be kept in time all the time. So let's talk about the ideal test. What could be one? The one which can clearly differentiate between a test variability from progression and is sensitive to localized supple changes. Because as we all know that in glaucoma, when it comes to the damage, the first thing is the RNFL, disc, and then last comes the visual field effects. So out of the different techniques, today we are going to talk about the imaging, that's OCT detecting the progression. But before that, let's have few lines about the disc progression, how to assess that. And for that, for evaluation of disc changes, there are 5 rules, 5 points, which we have to keep in mind, in which we start with the identifying the scleral ring that gives the detection of the borders. And last but not the least would be the disc hemorrhage. Likewise, in this particular case, as we can see that over a period of 8 years, there is broadening of RNFL and increase in beta zone parapapillary atrophy. So considering the limitation in mind, that is a subjective method, let's talk about the revolutionary change in the field of glaucoma diagnostic armamentarium. That's with the help of OCT. Because of faster scan rates and accurate segmentation of the anatomical boundaries, it gives us an improved visualization of the smaller details. And the progression can be detected in the form of a GPA, that's guided progression analysis. And this is a typical printout which the machine gives when it comes to assessing the progression, where with the help of the optic disc cubes, the machine compares the RNFL thickness measurement over a period of time and signifies it with the help of the data or the colors if there is any statistical change, significant change is there. Likewise, when we talk about the visual field, we say event and trend analysis. Similarly, here also we can divide a progression into two groups. Could be an event analysis and a trend analysis as well. In event analysis, basically the topmost picture, the blue picture, shows the RNFL thickness map, where we can see that these two are the baselines and these two are the subsequent follow-up visits. The machine compares these two baselines with the subsequent follow-up visits, and this is the thickness change map, where you can see again the two baseline, and if the change is detected for the first time, it is marked in yellow and then it goes for the red. And you always remember this data, that if there is any change of 5 micron in a sector, it is suspicious of progression, and 7 to 8 is suggestive of progression. Only drawback is that because of the lesser number of scans, it is prone to inaccuracies. Now talking about the trend analysis. Now trend analysis, what the machine does is that it gives you a slopy manner, slope where you can just again detect the change over a period of time, and again this is detected with the help of the color coding, and also you can see that it detects the superior, inferior, and also the average RNFL thickness over a period of time. Now it also includes the average CDR progression graph. So in all, we can concise say that this tick mark denotes that there is a focal change. This tick mark denotes that there is a broader focal change, and this tick mark denotes that there is a diffuse change when it comes to assessment of the RNFL changes. And now talking about this particular objective method, what I was saying, that there should be some numbering system to that. So as you can see here, that the numbers are going down from 80 to 65, and again, just to remind you all that the RNFL decrease of 5 is suspicion of progression, and a decrease of 7 to 8 is suggestive of progression. If we keep this in mind and see this picture, definitely we can say that a patient is progressing, keeping other factors in mind which may cause an artifact due to progression. So while conclusion, I would just like to highlight a case here, which, as we can see, that they were corresponding, there was a disc damage and the corresponding field change. But we know that the corresponding field changes, they only come when there is loss of 40% axonal cells. But here you can see that how beautifully it was seen and picked up with the help of the OCT before it came on the visual field. So this is the importance when you talk about correlating the disc structure and the function. So in the end, this is my last slide, sharing some clinical pearls with you all, that clinical pictures should always be correlated. Different machine images cannot be interchanged or compared. Age-rated thinning should always be kept in mind, and rate of change in progression is suggested to be larger in suspects and eyes with mild glaucoma. Thank you very much.
Thank you, Dr. Shweta. I request one of our panelists to please sum up for the audience how useful you have been finding OCT for your patients in assessing progress, because traditionally we have been using visual field. So have you started using OCT for your patients to assess progression?
OCT is definitely going to change our perspective, because it is a subjective method and it is non-invasive also, and it is easier for the patient. Only thing in our setup, patients have to be repeatedly told that they should use the same machine. Usually they do OCT in one sector, then another hospital they go and do the thing, and they want to compare those one report with the other. That is the main problem. Otherwise, very beautifully the machines have been designed so that progression can be picked up. But it has to be stressed that it has to be in the same machine, and we have to have a good fundus examination so that to rule out the artifacts.
Panda, so you like to add something?
I think the topic is covered very beautifully in a short given time. I think the importance of OCT is being recognized more and more, and of course they are complementary, as is being already highlighted. So OCT does play a more as we understand more about OCT and use it more, we are getting more proficient in interpreting the images and how we correlate in the clinical picture. But I think essentially.
Thank you, sir.
Thank you. We'll move to the next presentation by Dr. Shalini Mohan. Madam is Professor and Head of Department Glaucoma at GSVM Medical College, Kanpur. She'll be speaking on systemic disease and glaucoma.
Thank you so much, Dr. Manish, and respected members of executive members of GSI and all the members present over here. We know whenever we are treating the patients with glaucoma, so many times they are using associated medications, they are having associated systemic diseases, and they show us that prescription that doctor मैं ये use कर रहा हूँ. So इससे कोई फ़र्क तो नहीं पड़ेगा हमारी anti-glaucoma medication का. So that is why I thought of emphasizing on few important aspects of systemic diseases and medications which patients are using. Now, starting with one of a case of a 50-year-old female patient who was diagnosed with glaucoma 1 year back, and she had normal intraocular pressures on one anti-glaucoma medication which she was using, and the past ocular history had nothing significant except that past medical history revealed that she was hypertensive on medication and there was no family history of glaucoma. But because recently she had a progression of glaucoma, and that is why she was referred to us. And on examination, the vision was 6/6 in both the eyes. Anterior segment examination was unremarkable with open angles on gonioscopy and normal central corneal thickness. We did a diurnal variation for her, and it was 14 to 20 millimeters of mercury in right eye and 12 to 18 millimeters in left eye. The examination definitely revealed glaucomatous cupping in both the eyes, and the visual fields, they revealed defect which was reproducible on the second visual field. Now the question is that despite the pressures being controlled, what are the other factors which can lead to progression of glaucoma? So we started the retrospective history. We inquired about snoring, and we know that snoring is associated with progression of glaucoma, but that was not present in that lady. Because she was hypertensive, so we put her on 24-hour blood pressure monitoring, and we know that nocturnal hypotension is associated with progression of glaucoma because of reduced in diastolic perfusion pressure. And what we found was that the lowest blood pressure recorded for that lady was around 4 o'clock in the morning, and it was 70 to 56 millimeters of mercury. So the thing is that then we had a discussion with her physician, and the medication was changed accordingly. She was on beta blocker, which was shifted to calcium channel blocker. So if we see this article from Survey of Ophthalmology, it shows that systemic hypertension is the most common association in the patients with glaucoma, followed by hypercholesterolemia, diabetes, and cardiac disease. Now, if we see the various medications which patients are using, most common one again are antihypertensives, along with antiplatelets and anticoagulants, followed by antihyperlipidemic agents and hypoglycemic agents. So we must keep these points in our mind that if the patient is hypertensive, there can be a history of nocturnal hypotension or obstructive sleep apnea, which might be associated with progression of glaucoma. So we need to get in touch with the physician and accordingly treat these conditions. The Baltimore Eye Survey and the Agna-Newmark study also find an inverse relationship between diastolic perfusion pressure and progression of glaucoma. The critical value which was found to be normal was 50 to 70 millimeters of mercury, below which likelihood of glaucoma progression increased dramatically. Now, if we talk about various antihypertensive beta blockers, we know that if added, a topical beta blocker, if added with systemic beta blocker, they lead to incomplete reduction of intraocular pressure. Moreover, systemic and topical, they produce an additive cardio-inhibitory effect. If the patient is cardiac patient, we need to be careful. Now, many patients, these are using thiazide diuretics, and they can sometimes lead to acute primary angle closure glaucoma because of because of forward shift of iris lens diaphragm, and the diuresis they induce, they can be increased by concomitant use of carbonic anhydrase inhibitors. So if we are giving Diamox to our patients, especially elderly male patients, we should be very, very careful that the diuresis they induce, and that may lead to significant discomfort, especially during this winter weather. Now coming to cardiac drugs. Now aspirin, which is very, very commonly used, which it can also sometimes lead to secondary acute angle closure glaucoma, again due to anterior shift of iris lens diaphragm. Besides leading to sometimes choroidal hemorrhage or exudative ARMD. Besides this, there is a case report of non-ophthalmic eye where warfarin led to bilateral ACG. So these points should be kept in mind because sometimes patient might present to you with these problems. One point I wanted to highlight in the patients who are using digoxin. Now, it is a known factor that beta blockers, they may interfere with binding of digoxin levels, and therefore they can lead to increased concentration and toxicity of digoxin, and therefore if patients on such medication, we need to monitor it very carefully. Rather, we should ask the physician to monitor it very carefully. Now coming to diabetes, we know that diabetes, there is association in increased incidence of glaucoma in diabetes, but neovascular glaucoma is common in PDR patients. But whenever we are using anti-hypoglycemic drugs, we need to be very, very careful because adrenergic agonists, they can decrease the effect of insulin and they can promote hyperglycemia. So again, we have to be careful. Then regarding systemic carbonic anhydrase inhibitors, they may increase the blood sugar levels of the patient because of the hypokalemia they induced. So kai bar patients, they say that Diamox khane se sugar बढ़ गई, but that actually can happen. So we need to be careful. And then we all know the glycerol has to be avoided in diabetic patients. Another case I wanted to highlight of a very 22-year-old female, and I'm sure that some of you must have seen these kind of case also, who was using spectacle for past 12 years, and she had a headache and she took some medication, and suddenly there was loss of vision, and she came to us with headache, nausea, vomiting, and very poor vision. So while examination showed that vision was hand movement in both the eyes, and she was severely photophobic, unable to open her eyes. Now, on slit lamp examination, we saw that there was bilateral circumciliary congestion with corneal edema in both the eyes and extremely shallow anterior chamber. And IOPs were in the range of 43 millimeters and 48 millimeters of mercury with mid-dilated pupil. So as we see all these clinical features, it is a typical case of bilateral acute angle closure glaucoma. But sudden onset in a girl who was myope. So we looked out for causes of bilateral acute angle closure glaucoma, and we know that most common these are the systemic medications which can lead to such a situation. Besides general anesthesia, snake bite is another cause of bilateral acute angle closure glaucoma. Microspherophakia and Vokoyanagi-Haradas syndrome might be another cause. So we inquired the history of systemic medication with the girl, and when retrospective history revealed that she took topiramate for migraine, and which led to bilateral acute angle closure glaucoma. So this is again a very, very commonly used drug and not just this, there are several other drugs, antidepressants and anticholinergics, which can lead to this kind of situation. And many a times patients, they do buy over-the-counter drug and use these prescriptions like antipsychotic, tricyclic antidepressants, SSRIs, which are very commonly used nowadays, sedatives, which are although not available that easily without prescription, but patients do arrange. Then anti-Parkinsonism drugs and antispasmolytic are also can lead to this kind of situation. So what are the diagnostic feature? We need to do anterior segment imaging. UBM is the ideal for such a scenario, which might reveal these kind of dense area in the supraciliary area. Or you can do an ultrasound, anterior, that with water bath if you can do, you can actually see this hypoperfused area. So management is to stop these drugs. Systemic and oral anti-glaucoma medication needs to be used. You can use topical anti-glaucoma depending on the intraocular pressure. It can be beta blocker, alpha agonist and carbonic anhydrase inhibitor. Prostaglandin analogs and pilocarpine has to be avoided because they can aggravate the situation. Topical steroids are must in such scenarios. Cycloplegics you have to give. Contrary to patients of pupillary block, here we need to give cycloplegics. But no laser eye dot mean these patients, and if you treat properly, many a times these patients, they tend to resolve.
Can you sum up, because
Yes, sir.
already time is over.
Yes, sir. Sir, I will come to last slide. So to summarize, I would say that we need to be observant about systemic issues and medications. Glaucoma, if progressive at now, normal intraocular pressure should be investigated for certain of the systemic medications. Sometimes 24-hour blood pressure monitoring is very, very important, and check for concomitant medication. Certain factors should also be considered, like patients doing Valsalva maneuver. And regarding pregnancy, I would like to highlight that treat it beforehand, before the patient gets pregnant. Thank you so much for your kind attention.
Thank you, madam. We'll move to the next presentation by Dr. Amit Pandey. He's a consultant at Center for Sight, Surat, and he'll be speaking on MIGS. Meanwhile, we can take one or two questions. Any question we have for any of the speakers? Request one of the panelists, like, in which patients of glaucoma do you think a systemic evaluation should be considered? That's you, madam.
Basically, glaucoma is an elderly disease, so we have to take the medical history properly once we are ready to start the medications. Not only for the first visit, each and every time whenever the patient is coming, every time you have to ask whether the patient has developed any kind of new problems or any kind of new drugs they have been started with. That is very important, and that should be recorded in the file. And any kind of side effects the patient is facing because of the medications what they're using. All these records should be there so that we shouldn't miss it.
I'll start, sir. Yeah, good afternoon, everyone. Thank you for this opportunity. I'll be talking about minimally invasive glaucoma surgery and its emerging role in our current scenario in glaucoma management. We are all aware of this. It's the leading cause of irreversible blindness in the country. Most of our patients are undiagnosed, and even those who are diagnosed, most of them remain untreated or poorly treated. Right now, in our scenario, majority of us, we practice glaucoma, where majority of our patients are on medications and probably laser therapy wherever it's available. And once the glaucoma progresses to a severe or an advanced stage is where we do a surgical management, mostly trabeculectomy. When that fails, tube implants, and when everything fails in an absolute glaucoma stage is where we usually do a cyclodestructive procedure. We all are aware of these problems with medical management, where compliance is probably the biggest issue with our glaucoma management right now, where almost 60% of our patients don't adhere to their prescribed regimen. And when the patient is on multiple medications, this problem is much more. Ocular surface disorders, systemic side effects, poor quality of life with patients putting on multiple drops daily and dependence on the other family members, and fluctuations in the diurnal variation in the intraocular pressure. Whereas we know the benefits of surgical management, we have a more stable IOP, lesser visual field loss, lesser adherence and compliance issues, lesser ocular surface disorders, and much better quality of life. But right now, before the advent of MIGS, in mild and moderate cases, we did not have any surgical option, where most of our trabs and tubes were done in severe and advanced cases, because the risk of trabs and tubes outweighs the benefits in mild and moderate glaucoma. So this huge gap between our medicated patients and patients landing up with trabeculectomy can be safely and efficaciously filled with MIGS. What is MIGS? MIGS is minimally invasive glaucoma surgery. It's applied to a wide variety of implants, devices and techniques that lower the intraocular pressure with less surgical risk. That's the main important point here. Than as compared to a trab or a tube surgery. So where do we do it? We do it in mild, moderate glaucomas, especially those patients who are undergoing a cataract surgery. We can combine this procedure. It's a 5-minute procedure where we can do it, especially in open angle glaucoma, pseudo exfoliation, pigment dispersion syndrome. Patients on multiple medications who are allergic to medications, contraindicated, non-compliant patients, and those patients who are keen on getting a glaucoma surgery. Why mild and moderate glaucomas only? Because the aqueous drainage is happening through the natural pathways and the intraocular pressure is limited to the physiological levels only, where we maximum can get around 25-30% reduction in most cases. And in advanced and long-standing glaucomas, the collector channels in the Schlemm's canal are known to collapse. So they might not work in advanced cases, this surgery. Contraindications, like we discussed, advanced glaucomas, advanced phase loss, angle closure with extensive pass, secondary glaucomas, especially neovascular and uveitic glaucomas, extremely high IOPs is where we preferably do a trab. Glaucomas related to increased episcleral venous pressure. Some people are trying it in angle recession and pediatric glaucomas. There are some special indications where we can do it in post-filtration surgery as well, where the IOP reduction required is not very high because conjunctival scarring is not relevant here. Thin scleras, staphylomas, where we can't touch the sclera, we can't do a filtration surgery. This has its special indication. Congenital and developmental glaucoma, we are already doing goniotomies, so this is something similar to that. And angle closures where the angles open up after a cataract surgery. Right now in India, we are mostly having a few of MIGS procedures where we can do an implant, which iStent and iStent injects are the only implants available now. We can do a trabectome, again the cost is very high, KDB, Cahook's dual blade, GAT or suture GAT, and bang surgery. I'll skip the case. This is the iStent Gen 1. It's one of the smallest implants to be, one of the smallest medical devices to be implanted in the human body. It's made up of titanium, which is heparin coated, and it goes in the trabecular meshwork to drain the aqueous through the natural pathways. This is how the injector looks like, and this is how we implant it in. We target the trabecular meshwork, and the button that is there on the injector, we just press that, tap the implant to see if it is in position. It is done with direct gonioscopic view under very high magnification. A little bit of blood regurgitating is a very good sign that you are in the right plane. Confirm the position, and you are done. This is how it looks intraoperatively. We usually put it in the inferior and the inferior nasal angles. Again, on slit lamp also, sometimes you'll be able to see it. This is on gonioscopy view on the slit lamp. Don't want to discuss this. Then comes the iStent Inject, or the generation 2, which has got 2 implants in the same injector. That's how the injector looks like. And this is how you implant the inject. The sleeve is first retracted and you go perpendicular to the trabecular meshwork. The trocar is inserted into the trabecular meshwork perpendicularly. Create a small dimple on the trabecular meshwork. That's the dimple. And you press the black button. And you come back out slowly. And you go 2 clock hours inferiorly and repeat the same steps. Then there is KDB, where you excise the trabecular meshwork, and a modification, an Indian modification of that is bent angle needle goniectomy or bang surgery, where you take a 26 gauge needle and you excise the trabecular meshwork. Around 100 to 120 degrees of trabecular meshwork is excised.
Thank you, Dr. Amit. Please wind up.
I'll just conclude. So MIGS is not an alternative to filtration surgery, and it should be, there's a huge population of mild to moderate glaucomas where we can use this to stop the progression into severe and advanced stage. And for the ophthalmologist, MIGS can do for glaucoma what anti-VEGFs have done for retina. And for the young glaucomologist, this gives us a level playing field because it's new for everyone. And MIGS has created a paradigm shift in the management of glaucoma worldwide, and it's high time that we practice it in India. So it's a versatile surgery. We have done it for a 10-year-old and a 92-year-old patient as well. Thank you so much.
Thank you, Dr. Amit.
The iStent Gen 1, the MRP is around 69,000, and the iStent Gen 2 is around 1.5 lakhs, the MRP. The Gen 2 has got 2 implants in it, where, like I showed, we implant both the implants in a single patient, whereas the Gen 1 has got a single implant. So that's the difference, main difference. The IOP reduction is better with Gen 2. That's what both of them are available in India. It's not made in India. It's from a US based company called Glaucos.
I think there have been a lot of discussion last few years about MIG, especially iStent. I request our chairperson to say what has been your take on this. Do you think MIGs can be a part of glaucoma management in India?
I think over a period of time, this concept has been coming and getting a little more wider acceptance. We have just started seeing this happening in India as well. But I think if you look at the, why we need these stents basically is because you want a safer procedure. We have very effective ways of lowering intraocular pressure, but they have their own set of complications, and our endeavor is to, lower the complication, and that's where actually these MIGs fit in. But their IOP lowering efficacy is definitely not as good as the traps or the tubes that we have been seeing. So right. I think there's always a little bit of a, like he highlighted that there's a bit of a gap there where we are trying to fit in these implants. But if we look at our scenario, they're very expensive actually. I think the one MIG surgery will cost you 100,000 rupees at least, whichever implant you put is in excess of that, plus you have the cost of the cataract surgery and the IOL implantation. The total package actually goes beyond to 1.5 lakhs or maybe more. And the IOP reduction you get in term is, sometimes it's actually questionable in that sense that because this is being done with the cataract surgery, so cataract surgery itself lowers IOP, and there's been a lot of debate in literature if you read whether this is because of the cataract surgery alone or how much is a part, with the MIG is, on this iStent or iStent inject is doing. So, but one thing is definitely there that there is a IOP reduction because now there's enough data to suggest that cataract surgery lowers IOP. But on top of that lowering, there is some amount which is also due to, these implants. So now that data is kind of there. So to say that do these implants lower IOP on and above, over and above cataract surgery? Yes, they do lower. The next question would be, can we achieve same amount of that IOP reduction with other drugs? So we do, because we have no very effective drugs to achieve similar IOP lowering. So if you are using any of these MIGs, how much IOP lowering you get is somewhere around 20 to 30%. 30% is actually being very optimistic. 20%, 25 is probably more realistic. I would say 20% is more realistic.
In my 45 cases that I've done, sir, I've achieved around 30% reduction, and number of medications have
I'm
decreased.
speaking
from
for the literature in general,
Right,
you
sir.
know, because I'm not speaking my experience. I'm
Right,
talking
sir.
the literature in general. So I think that's the impression we get is somewhere between 20 and 30% you get that IOP lowering, which can be achieved by way of drugs also, and also doing SLT. SLT is actually very underutilized in terms. So what these these techniques basically achieving is to kind of modify your trabecular meshwork area in some way so that you get more IOP reduction, and we have alternative methods. So put the story short, there is a place for the MIGS there, but this is still being evolving, and the major drawback that we have now in our population, is basically the price. So if the price is too high for the amount of IOP that you
we have a good alternative for that. The bang surgery is a very good alternative, where we are just using a
Yes.
26 gauge needle, and for patients who can't afford an iStent, definitely bang
Yes,
is a
bang
good procedure.
definitely. I would say that I would recommend that.
Right,
I
sir.
think bang is the only procedure which I do most frequently, actually, rather than others. But
Same, yes.
but again, the bang experience is very less.
True.
The experience with the bang is less than 1 year, so we don't know what happens after 2 years, 3 years, 4 years. We
Definitely,
don't know.
sir.
So you can't really recommend that as a routine procedure.
Right, sir.
So we had seen a 1 year follow-up of a bang surgery done in another eye with a phaco, and the other eye was done with a trabeculectomy, phacotrabeculectomy. The one eye is doing well, although the patient has some complaint, they have some irritation, some watering and like that. But the IOP is well controlled, because that patient was sensitive on 2 medications, allergic to that one. But the bang surgery alone has not done, and he need another surgery, I can say within a year itself. So I think there is definitely some scope, but not in advanced glaucoma.
No, mix is not that something which is new. It has been there, because one of the means probably if you analyze it that way, that why it is there for so many years and is still not becoming popular. Especially in Indian scenario, we have to consider the cost, which is a very big issue. But according to me, these things are also probably pushed by the companies. And there are various, means probably we all understand how do the company try to push these things and then try to make it more popular. Also, it is not, because the learning curve is also there in this, because there are many cases where reported that sometimes these implants are lost. You don't know where has it gone. And then 1, 2, even sometimes even some of the letters says 3 implants. So I don't know, then why not all 24 clock hours, 12 clock hours put 12 implants? So it is not that, the picture is not that rosy as it appears. So there are limitations, and it has been there for so long, and none of the implants have really so far picked up. There are so many in this mixed category, there are so many surgeries, but none of them have really picked up.
Sir, I have got a question to the esteemed panel, sir. What do you recommend, and what is your take about combining GSL, that's GSL along with your cataract surgery for the angle closure cases, sir?
I think if you're talking of the angle closure case, there are many factors actually what exactly you want to do in it, but the short reply would be that I would prefer a cataract surgery alone in angle closure and see what happens with the IOP, because if you do the cataract surgery and don't do any other glaucoma procedure, the chances are, I would say 80% the IOP is going to come down to a reasonable level from where you can control with the drugs, except in a very advanced case where you want to have cataract surgery as well as glaucoma surgery. So I think bank procedure or any of these MIGS in case of angle closure is a difference. So I have a lot of reservations for angle closure patients. Even when you're combining with cataract surgery, because that's the place where cataract surgery itself can significantly lower IOP, maybe 30 to 40%, 50% sometimes I would say. So there is very hard to assess actually whether your MIGS is actually doing any good or it's not doing any good. But for open angle glaucoma is a little different story, and that's where I would say these MIGS would have some role. And bang, of course, is my favorite as of now because it's very cheap.
Yes.
For that reason, yes.
Pocket-friendly for
Yes.
us. Thanks.
Thank you, sir. Nice to have so much discussion. We'll move to the next topic of artificial intelligence and augmented reality in glaucoma.
Yes, sir.
Dr. Prasanna Venkatesh is a senior glaucoma consultant at Mahatma Eye Hospital, Trichy.
Thank you, sir. Thank you, Glaucoma Society of India, for this opportunity. So, for the next few minutes, we'll see on artificial intelligence and augmented reality in glaucoma. Is it the hype, or is it something that is real and not the hype? Yes, yes, my dear friends, it's something real and it is happening. So, it started right from the 2D and 3D face recognition that we started using to unlock our smartphone. And slowly we had the fingerprint to unlock the smartphone, the fingerprint and the finger vein patterns that we started using, the iris pattern, and then came the first unmanned car which is recently launched, and then there is NASA launching the first unmanned flight as well in the National Aircraft System. So why glaucoma or why ophthalmology? Because ophthalmology is an image recognition field. There are so many images in ophthalmology, and fundus is one such interpretation. So here you can see that this is one of our articles, mine in April issue 2022, which I'll be dissecting to you. It's nothing but it's a human inspiration. The central nervous system and the peripheral nervous system of the AI mimics a human inspiration, and our circuit is called human in the loop training, where human intelligence goes hand in hand with the machine's intelligence. So how did we create our artificial intelligence baby? We annotated because there is something called the black box dilemma. Why the AI tool predicts the way it predicts, nobody really know. That's the black box dilemma, which we wanted to break by bringing two human interfaces. Human marks it, the machine processes it. Again, the humans will validate whether it's right or whether it's not right. So you can see that the annotation is done by the humans. We teach the machine what is the disc, what is the cup. So again you can see where is the macular area. This is a human actually guiding the machine that this is where you will have to see for what you have to see. So that's why we are trying to break the black box dilemma. This is how the vertical cupping is being taught to the machine. Multiple images, more the data, more the big data, we get see even the simple RNFL defect can be taught. A slit defect, an arcuate defect is continuously being taught to the machine. Even a bionetting sign, which is a non-specific one. So every signs involving glaucoma is first fed to the machine. The machine is taught just like a baby, a peripapillary alpha beta atrophy, and to name a few, and so on. So a single image is annotated as deeply as possible, so that the more we teach, the more the machine can also predict. So this is an artificial terminology where over training we observed that the objectness loss and the classification loss, which is actually good, it decreased over time with the training, and even the precision, recall, and the mean average precision improved, suggesting that the machine is learning in the right way. So the predictions, not only this image is predicted as glaucoma or not, it will be predicted whether it's a mild, moderate, or severe damage, and along with it all the intricate parts are also predicted. Every single sign is also predicted, not only the diagnosis, but along with the diagnosis an RNFL defect, a splinter hemorrhage, a laminar dot sign. In that way the black box dilemma is solved. You can see the predictions are very minute. It's an explainable AI. That's the way we are trying to go to. Which AI is explainable has more value than an AI which is not explainable, which is slightly dangerous. We have developed an AI with good sensitivity and specificity using true color confocal images, thus improving the interpretability. We have used true resolution high images, and not only for the posterior segment, even for the angle currently a multimodal AI is being developed by us, where the trabecular meshwork, the scleral spur is marked, and we have currently developed a protractor. As you can see here, once the anterior segment structures are marked in this ultrasound picture, a protractor has been developed by us where the angles are being taught to the machine, how it has to really interpret the way it has to interpret. So this is going in detail and trying to cover or teach the machine how to mark the angle of the anterior chamber. This is an ultrasound picture. Then we can superimpose lot of other details, and this is the exact schematic plan with which we are going. And with the UBM we can add the anterion, the ASOCT, the Scheimpflug images. Thus the AI will be much more better. So there are many papers in IJO from our institute and myself, and these are some of the references in the October issue 2021. The June you can have the blockchain technology in AI, and then recently we had one more commentary on the AI. And then there is the technology called augmented reality, which is slightly different from AI. And these are the two apps which are readily available in the market, one for the Android and one for the Apple, which we have innovated and launched. So what is augmented reality is, how can we really bring the three-dimensional structure in the 3D world itself? Eye being a 3D, can we really bring this three-dimensional model in 3D? Yes, it can be done with a simple smartphone. So every one of us have a smartphone. What if we can bring the structure in 3 dimensions? So that's what we have done, and we have used real images, as you can see on the right hand side. This is the image that you can see in your smartphone, which is happening here. This is something like a simulative learning, and as well as for a counseling, where you can see real fundus images, real angle structure images have been coded, and examination of the patient can be done, and EMR can be integrated in 3D, and learning can be in a next level of simulative glaucoma learning. So this is again another headset which is slightly a costlier version of it, but with this headset you can see on the right hand side, my dear friend seems to be moving through thin air, but through his eyes he is actually examining a case of normal tensive glaucoma with splinter hemorrhage, who is not being very compliant with his medications. Even the patients can be counseled, or the attenders can be counseled by wearing this, so that they'll really understand their process much better. And again you can see this is another case where for want of time I'll just skip. So this is the three-dimensional module, and this is the innovation of ours which is published in Jan issue 2022 and the August issue 2022. So AI and AR, there is no arm wrestling between the doctor and the machine. The machine and the doctor has to go hand in hand, and it is together where the humans will always be on top and will be monitoring the machine, and we both together will be working towards a better humanity, which is called human in the loop training, where we will be breaking the black box dilemma, because it's an explainable AI and an explainable augmented reality module. So ours is a 60-second app where it's a software with the imaging, it goes into the software with no chair time. The interpretation and diagnosis are well arrived because of this particular innovation section that you can see which we created. So thank you once again for this opportunity. Thank you, dear all. Thank you.
Thank you, Dr. Ramesh. I think we'll move to the next presentation by Dr. Amit. He'll be speaking on management of coexisting cataract and glaucoma. Dr. Amit, as we all know, is a senior glaucoma consultant and head of department at Choitram Netralaya, Indore. Do you have any questions for any of the speakers or panelists? Any comments? Sir?
So, because of paucity of time, we'll start, I think, now. So I'm going to talk on management of coexisting cataract and glaucoma, no financial disclosures. So we all know that this is a very common disease because of the aging process. So how to manage this condition to promote the best visual outcome is the main important question which arises in everybody's mind. So the initial decision making is crucial in determining the type of intervention in these combined diseases. So approach to a patient with cataract and glaucoma, you have three approaches basically. You have a cataract extraction with IOL implantation alone, then you have a sequential surgery where TRAB is done, followed by cataract surgery later on, and then you have a third option which is a combined cataract and glaucoma surgery. So first we should know what are the indications for cataract extraction alone. So the indication is that should be a visually disabling cataract with IOP under good control. There should be a mild glaucomatous damage, minimum visual field loss, on one or two well-tolerated topical anti-glaucoma medication, and the patient should also be compliant with these anti-glaucoma medications. So these are the indications for cataract extraction alone. Now coming to the sequential surgery where trabeculotomy is done first or a glaucoma procedure is done first, followed by cataract surgery. This is called a two-stage approach. The indications being when the glaucoma dominates the clinical picture, there is a significant optic nerve damage, there is an advanced visual field loss, there is an uncontrolled glaucoma despite maximum medical therapy, or cataract surgery can be done 4 to 6 months later once the filtering bleb is well established. So this is basically the indication for this two-stage procedure. Now what are the indications for the combined surgery? In India, the most common indication for a combined surgery is economic issue. But what are the other indications? Failure to achieve target pressures by medications, issues related to compliance, adherence and drug-induced side effects, borderline controlled IOP, disease progression or advanced glaucomatous optic atrophy despite maximum medical therapy, and uncontrolled glaucoma but an urgent need to restore vision with two operations are not feasible. So combined surgery is the most common indication in our country because of the various reasons which I already mentioned in point 1 and point 2. So coming to the surgical considerations, first preoperative consideration is we should know whether the significant visual loss is due to the cataract or the glaucoma, because patient always expects a better vision. He thinks that the cataract surgery gives 6/6, and even with the glaucoma combined surgery or a glaucomatous surgery, he is going to restore vision. So proper counseling is a must after determining what is the main cause of visual loss, whether it is cataract or glaucoma. If it is glaucomatous, we have to counsel to the patient that this vision loss what is there is never going to regain back. So we are doing this procedure to retain whatever is left. Slit lamp examination should be done properly to look for any pseudo exfoliation, shallow AC, and if it is a myotic pupil, you should be prepared how you are going to deal with this myotic pupil. Fundus examination again to look out for the glaucomatous optic atrophy, and also to look for any macular pathology which is going to give a poor visual prognosis. Coming to the operative considerations, you are all trained phacosurgeons or cataract surgeons, so you should be well versed with the devices or what are the things you are going to use to tackle this myotic pupil. Coming to viscoelastic, sodium hyaluronate is very important because it maintains the flat anterior capsule and it deepens the AC, and whenever you wash it out also, it comes in one go. So sodium hyaluronate plays a very, very important role. Coming to the operative considerations, your access should be adequate size, and IOL selection, you can use a PM or acrylic, but if there is no capsular support, ACIOL has to be avoided. You can implant an SFIOL, or I would still recommend an iris law better over an SFIOL because the amount of dissection with SFIOL is more, or you can go with the newer Yamanese technique or the newer techniques of SFIOL. Coming to the techniques, the cataract extraction after filtering surgery, cataract extraction should be positioned to maximize the bleb survival, which is very, very important. The incision site depends on the location of the filtering bleb. Usually the filtering blebs are located superiorly or superior-nasally, so temporal location is the ideal location. We should always do a slow motion phacoemulsification. We should not traumatize the bleb when you are doing the cataract surgery. So phaco with foldable is a choice of surgery, and most of the time we do come across with synicus. So syniculysis is a very, very important step to be done. Coming to the triple procedure, that is the combined surgery, you have the single site technique and the dual site technique. Single site, that is cataract surgery and the trab is done to the same site, usually it's the superior site. You can combine SICS or phaco with the trab. If it's a twin site, then usually that is the preferred because most of them are temporal phacosurgeons. So cataract is done through the temporal side and the trab is done to the superior side. Both of them are giving the IOP reduction which is there. It is not statistically significant. Only the thing is the surgical time required for the combined the twin site surgery is a bit more. So I'm going to show you simultaneous videos of these two combined surgeries. So coming to few important techniques, basically whenever you take the stay suture, whether you take a superior rectus bradal suture or the corneal stay suture, you make sure that you go in a one go, you don't have multiple punctures. Your stay sutures are very important. Every surgical step plays a pivotal role when you're performing the surgery. So once you have taken the stay suture, you always mark the conjunctival flap, do the subconjunctival dissection, identify the bleeders. Never do a rough never do blind cautery. Always try to identify the bleeders and give gentle cautery. The coagulation, the cautery power should not be more. Always mark the scleral flap. If it is an SICS trap, I do mark at 6.5, and if it is a phaco trap, I do mark at 3.5. Marking of the conjunctiva and the sclera is very important because you should know what is the size of the flap you have created. You can create a triangular flap or a rectangular flap, whatever you are comfortable with. Again, choice of antimetaboloid which you are going to use. You can use the sponge or you can use a subconjunctival mitomycin before the start of the procedure. It is your preference, but make sure that whatever you use it, you could calculate the dose according to the need based of the patient. Making of the scleral flap is very, very important. You should try to lift the apex of the flap and just touch the cutting edge of the 15 number blade at the junction so that you get a nice uniform flap. And this flap will be of good size only if you not over cauterize it. If you over cauterize it or do a blind cautery, there will be shrinkage of the scleral flap. So when you have done the scleral flap, you will always see that the mismatch between the scleral bed and the scleral flap. That is because you have over cauterized the scleral tissue. So this is very, very important. Never over cauterize it. When coming to the SICS trap, the normal steps of SICS continue. And when you are doing a twin side phaco trap, now you shift. Once you have created the scleral flap, you shift temporally and do your normal cataract surgery. So for phaco trap, I would recommend a slow motion phaco, and for the SICS trap, all the steps continue. Now, important step, I'm just going to skip one of the videos so that because of paucity of time. Coming straight to the trap techniques. So you can do the trabeculectomy either the internal ostium, you can prepare it either with a 11 number blade and MVR, or the best would be a Kelly's punch. So Kelly's punch gives a very good control when you are doing that when you are preparing the internal ostium, because your chances of iris prolapse and AC shallowing is minimized because that gives a very good control. So you can make about 2-3 punches vertically and then 2 lateral. There are different patterns. You can have an L pattern of internal opening or the mushroom pattern of internal opening. So once you have done the internal opening, do a broad based peripheral areorectomy. Then coming to the closure of the scleral flap, this is very, very important. There are different techniques. You can put an apical intermittent suture, or you can put a single apical releasable suture, or you can put two releasable and one apical suture. So the technique of suturing is very important. I am showing you the technique of releasable suture in the SICS case. You first pass the suture into the clear cornea parallel to the limbus, and then from the clear cornea perpendicular to the limbus, and then into the scleral flap. 4 throws are taken, and these throws are passed out, so that you get a horseshoe lace kind of suture technique, and whatever exposed part, you withdraw it out, and you can pull it and titrate it. So because of paucity of time, I'm just going to finish my talk. Thank you.
Thank you, Dr. Amit. I think we started around 5-10 minutes late, so
it's okay. I think we'll otherwise push off all the halls behind.
We can take one question, maybe if you have any question or any comments, or we can close the session. Sir, yes, Nayak sir.
No, so there is no question right now, but then basically the closing remark, the session was good, and different topics which were discussed, all were important. And but according to me, as I said earlier in the session, or the topic of mix, that one has to accept it with a pinch of salt. So it's not that something which is very rosy as the pictures are being produced. And the systemic features which were discussed, that is also important. The progression in OCT, because all OCT machines are not same, that point was highlighted that it should be on same machine. But the same machine should have features for registration, so that the repeated photograph when you are taking, it should be exactly at the same location, because even if it is slightly tilted or shifted, your total progression will go haywire. So it will be absolutely wrong. So those points you have to consider, because it's a very small in microns we are dealing with, the difference and progression. So that point you should keep in mind. And artificial intelligence augmented, that for me also it is very new. So first of all, we have to, yesterday I was trying to understand with Venkatesh, and I said keep it simple. So still I thought it was not that simple. So and Amit Porwal, anyway, that topic is very important and it's very frequent, which he covered it very nicely. But only thing, with paucity of time, he could not elaborate on some of the points, but it was a good summary of the topics. Thank you very much for this session.
I think we look forward to artificial intelligence. I think that's a great area. Yeah. But it is still, I think that black box phenomena still persists. You have to make.